everyone. Thank you so much for joining us. My name is Mary Margaret Gleason, and I'm thrilled to be part of this stellar group talking about a set of early childhood mental health consultation programs that cover multiple sectors in Louisiana.
And before we start, again, welcome to the Center of Excellence for Infant and Early Childhood Mental Health Consultations Conference, Equity from the Start. My name is Bethlehem Ishatu-Yimar, and I will serve as your session moderator. I am joined by Chris Ward, who will serve as our technical host. This session is being recorded. Transcription is available through the Zoom platform. And should you have any questions, please feel free to relay your questions to the chat. We will have time at the end of the session for questions and answers with the presenters. That said, I'd like to pass it over to the speakers, which will be Allison Trigg, Faye Chen, Juliana Finelli, Mary Margaret Gleason, and Sarah Hinshaw-Fuselli, who will be conducting a workshop with the group. Thank you all so much.
All right, I apologize for that. So we're going to go ahead and ask you to tell us a little bit about who you are through a poll. And while that's going up, I'll also share with you our disclosures, which is just me. I have, as you can see, I serve as a consultant, I have some sit on boards of directors, and am grateful for some grant funding. We can go to the next slide. So our goal today is to talk to you about a model of consultation that we and others have developed across the state of Louisiana in multiple sectors. I'll be talking to you a little bit about the shared elements of those consultation approaches. And then you'll hear about the specifics of each of the models in childcare, home visiting, primary care, and perinatal settings from experts in each of those areas. And this really is a stellar group. We'll save some time for discussion at the end and talk a little bit about where we hope we're going. So on the next slide, I mentioned that we have multiple sectors where we provide consultation, and thinking chronologically, and we can just go ahead and hit the 4 animations, thinking chronologically about where children have access to child and family serving professionals. You can see that we have chosen to address consultation in perinatal healthcare. You can partly see it, I guess. In primary care, and we know that many children have spent time in out-of-home childcare as well. Although the rates of utilization are not as high for home visiting, we know that home visiting services provide supports for families who are at particularly high risk of being exposed to adverse social determinants of health and inequities, and so I've chosen that as one of the other settings where we provide consultation to support the child and family serving professionals in those sectors. On the next slide, I do want to acknowledge that although I'd like to say that we only follow where the children are, we did also have some guidance of directions for the initiation of some of these elements and also the adaptations, thanks to the funding sources that we were able to partner with. On the next slide, I want to emphasize our goal is really to expand the capacity of our partners to meet the needs of the children they see every day, recognizing that they're incredibly skilled, but may not have the training to address early childhood mental health concerns. We do that through with a couple of goals. First, we want all children in those sectors to receive the support to have healthy, for healthy mental health. We want to make sure that for children who are at risk of developing mental health problems, our partners are able to identify them and support that early identification and have a plan to provide first-line approaches for management of those problems as well as preventative approaches. And when they do meet children who have needs that go beyond the scope of their training in their setting, we want to make sure that they can link those children and families to specialty services for intensive mental health supports. We also have goals for ourselves and for our programs, and those are twofold: to recognize and mitigate the impact of the inequitable systems and services that interface with young children and their families, and to advocate for systemic changes that will address those structural inequities. We want to make sure through our programs, through consultation and through this advocacy, that every child starts life with the supports that they need. And we do have some ways that we know that consultation can level the playing field. We can select and have selected geographic areas that are traditionally underserved. We can make sure that we're providing consultation to professionals who work in child serving domains that may be affected by structural inequities. Within those professions, we can choose the practices and settings and centers who serve children who are most at risk of being exposed to structural inequities and not having access to early childhood mental health services. And through our consultation, we do want to make sure that we're explicitly paying attention to and highlighting for our partners evidence of disparities, addressing implicit and explicit bias, and focusing on reducing and eliminating injustice. And just as one example, you can see in Launch, which was a federally funded program to provide consultation in childcare, primary care, and early intervention, the blue bars show the prevalence of African American or Black children in the region we served. And on each of our domains of consultation, you can see that we provided early childhood mental health consultation to a higher proportion of children of color than were represented in that population. We'll go to the next slide. So in our consultation, we focus on strengths. We know that relationships are the way that we can affect change, both in our practice and through the relationships that the providers have with families and children. We work to encourage and support effective communication strategies, making sure that our partners have the knowledge to use developmentally specific interventions based on the children's developmental age. And we always want to make sure that we're integrating the evidence base into the practices we offer. On the next slide, you'll see that we have some areas of differences across the models. And I'll ask you to just pay attention to some of those areas as we present our specific models of consultation. Who we serve, where they are. Pre-COVID, there was some variability in terms of remote consultation and whether we provided asynchronous consultation. The level of interaction directly with the family, the ability to have multiple levels of consultation, first line and follow-up second line with a provider, like a psychiatrist who may have different background and skills, and whether the consultation includes care navigation or care coordination. And as we talk about the consultation, I do want to highlight that all of this that we're going to be talking about has occurred in the context of the last 2 years, which has been shaped by the exposure to COVID, the fight for social justice, and want to recognize that our adaptations have really dramatically been influenced by the context that we serve, where we serve children. So I'm going to pass it over to Allison to talk about childcare.
All right, thank you so much, Mary Margaret, for that very good introduction. So I'm going to talk about TICs, Infant and Early Childhood Mental Health Consultation. And as you can see from our little banner here, we're in our 15th year. So we are very excited about that. Next slide, we'll go into some details about our team. So we work with childcare professionals, and recently, over the last 3 years, also with family childcare providers. We work with centers or the FCCs for 6 months. We can go in for visits typically every other week, and we're there for about a day, so what we call a day, so about 5 to 6 hours. So we spend a lot of time with the folks we work with. We have follow-up visits available for folks after they work with us for 6 months, and providers can come back and have consultation again for 6 months. So to do this, we have a team of 18 consultants across Louisiana with 4 faculty members at Tulane helping lead that charge. And then we also have 4 senior mental health consultants that are stationed around the state. We do our work through community subcontractors. So we work with several nonprofits nonprofits around the state, which then hire our consultants. So all of our consultants come from and are part of the community that they work within. And we felt that that was a really important part of building those relationships that Mary Margaret referred to earlier, so that we weren't just a team of folks coming in from Tulane as a university in New Orleans, but instead everyone on the team has a connection to their community. Just to give you an idea of sort of what our reach is like, I just grabbed some numbers from the last 6 months of 2021. And during that time, we served about 375, a little over that, sites with just over 1,800 visits. And I would say that these numbers are probably a little bit low because also, as Mary Margaret mentioned earlier, COVID has really impacted the ability to go into centers. So we have been able to offer more virtual visits, but I see from the poll that about half the group are doing consultation, and about 40% of you are doing consultation with childcare centers. So that doing virtual childcare visits has a host of difficulties to be able to talk with teachers, to be able to observe classrooms, to be aware of privacy and confidentiality. That I would say our numbers have been a little bit low, but we're getting them back up. Next slide, please. So actually, yeah, perfect. So I'm just going to go through the different goals that Dr. Gleason talked about earlier and sort of discuss how TIECHS has gone about reaching those goals. And so with number one being supporting healthy development of young children, we look at having success in this over the years in a couple of different ways. We've had program evaluations, and we've done observational research where we had trained providers on the classroom assessment scoring system. And after 6 months of consultation, all areas of the class, and it was the class pre-K, all areas increased, except for negative climate, that one decreased, so that was good. And then we've also asked teachers to tell us, self-report, how have things changed for you personally pre and post 6 months of TIECHS consultation? And teachers reported increases in their personal teaching self-efficacy, so how they feel about what they're doing in the classroom. And they also reported increases in how much they influence the children in their classroom, so as opposed to people outside of the classroom. And then they reported having increases in how competent they felt in supporting social emotional development. And that's a big part of what we want to do, is really support that social emotional development. And one of the things we were really glad to find about these different evaluations is we went back in 6 months after consultation was complete, so 1 year after the beginning. And all of these increases on the class and in teacher self-report were all still there. And we think one of the ways that we are able to get to that is that we have professional development built into our model. So you'll see in the last 6 months, we've worked with about 800 educators. Next slide. And we really support the use of using social emotional screeners. We train our providers on it. We discuss and encourage, and we talk with them about providing feedback to parents, because sometimes that's a difficult part of instituting a universal screen for all children upon enrollment and then every year after. So we have a big support of that. Next slide. And then goal number 3 is really looking at that first line prevention. And this is where we can support through child-centered consultation. So with parent consent, we then will use a targeted screener, so more targeted than that universal screener that we're supporting centers and doing on their own, and look at then creating behavior management programs for the classroom, talking to teachers and talking to parents. So we had about 100 child-centered consults over the last 6 months. Again, that number is a little bit lower than what it typically is with COVID. And then for goal number 4 is then for those children who show up as needing more supports, we start looking into what specialty services do they need in the community. And so as you can see here, over the last year, we've made about 200 referrals, and they're really quite varied. So Medicaid Part C, speech, occupational, parent-child, play therapy, family supports. And we also make, I think it's important to note, we also make adult referrals for teachers and sometimes also for parents. Sometimes we may be the first mental health provider they talk to, and we're able to bridge that link for the adults as well. Moving on to 5, the more difficult part of this work, but something that we've consistently tried to do in TIECHS, is to prioritize centers that have a greater number of children in foster care or who have more children receiving childcare assistance. And this way, we've been able to really focus on those children who may have a greater need for services. And then also looking at the folks within our team and making sure that they understand the difficulties or the inequities that may be in their particular communities. We serve a wide variety of communities, including suburbs, urban areas, and rural areas. So we really need our consultants to be aware of what inequities may exist. And then moving on, I think I'm getting near the end. When we look at 6, which is advocating for systemic change, we really have grown out of the understanding that we need to support children who have greater needs. And so to do this, we really work to be a part of our early childhood network communities and continue to advocate that consultation services are available for the greatest number of young children available. And we've seen the fruit of that effort with the moving into FCC. And I think that might be near the end. We're going to keep working on focusing on increased CCAP seats as well as increased funding for CCAP seats, because often the parent portion of that funding is a little bit too high for parents to be able to have their children in quality childcare settings. And I will sign off.
All right, thank you. So in Louisiana, we have had infant and early childhood mental health consultation in-home visiting. You can forward, please, Juliana, since 1999 in some form or fashion. And it really began more as a direct service model with some consultation being provided to home visitors about the home visiting clients who were being seen in therapy. The first evaluation was conducted and completed in 2011. And at that point, 50% of the teams in Louisiana had a consultant. And what they found is that participants stayed longer in the home visiting program on teams that had consultants, and those teams made more community referrals. So moving on to 2016, and some funding changes and opportunity came through the HRSA Targeted Innovation Award, and there was a shift to really focusing on consultation only and providing more structure to that consultation, kind of getting in line with the goals of some of the other sectors. The overall goal of that Targeted Innovation Award was to develop and retain a highly skilled workforce. And so as you can see in the evaluation that was completed in 2018 then, first of all, there was an overall increase in consultation because we were able to expand consultation to all of the teams in Louisiana, and found that trainings increased home visitor knowledge, increased home visitor self-efficacy, and that the home visitors really perceived support from the infant mental health team. So currently, the model has reincorporated some therapy in the form of evidence-based practice. Child-parent psychotherapy is being offered now through an NCTSN opportunity to have all the consultants trained and rostered in child-parent psychotherapy. So the focus is still on consultation and providing that service to the home visitors, but also direct services are being offered to about a quarter at the time. So in line with the parallel process, you can see here, the ways that these first several goals are reached is through home visitors being supported by mental health consultants, and then children and families being supported by the home visitors. And so what we learned from home visitors is that they really felt underprepared and overwhelmed by mental health needs, and that those needs were taking a lot of time, and that there weren't a lot of community resources available. So problems went unrecognized and untreated. And through the support of the consultants, the home visitors have been really able to focus on, developing that trusting relationship through that regular contact with parents, identifying developmental and mental health risk factors, identifying safety concerns, promoting those healthy interactions with the baby, reducing aloneness, and helping navigate the system. And of course, a lot of that is built into the home visiting models. And what the consultants are able to do is provide additional education, support around screening and monitoring, support around the self-efficacy of both home visitors and then parents, and then linking families to resources and treatment when necessary. Next slide. It's slowly coming, but I think what we're talking about systems. Yeah, so how this program helps to recognize and mitigate the impact of these inequitable systems and services. Louisiana McBeat is statewide. There are 19 teams, and just as a snapshot, you can see annually about 3,800 families are served, and these are Medicaid eligible families. When the Targeted Innovation Grant came about, as I said, we were able to scale that statewide. And so all the teams have access to this now. And in that 17-month period of the evaluation, approximately 6,300 consultations were provided to home visitors regarding 1,273 clients. The home visitors attended and contributed to 625 case conferences. And during that time, when no direct services were being provided, they were doing joint visits with home visitors. So when there was a complex question, a consultant can go out with a home visitor and do a joint visit and try to get a better idea of what's going on and what services might be helpful. Okay. And then just to highlight on this slide, again, trying to recognize and mitigate the impact, for a focus on awareness and knowledge. So as you can see, the content areas that were really focused upon were included trauma-informed care and diversity-informed practice. And home visitors reported new understanding of the etiology of many mental health issues. And this includes looking at systemic adversities and how those impact families. And then I also want to call attention just to the last bullet points there. The home visitors also reported feeling supported, but increased self-care practices on their own. And I think this again goes to the parallel process. And one of the things that the consultants encourage is self-awareness, self-reflection, and taking care of oneself. And that really seemed to hold true for the home visitors as well. And there you go, back to Mary Margaret.
Two years in and I still can't unmute myself. We will switch gears and talk about pediatric primary care consultation and a model of consultation that was started at Tulane in the Tulane Early Childhood Collaborative back in around 2016 and has been adapted and grown through the project launch that I mentioned in Lafayette, Louisiana, which continues to this day with some amazing clinicians out there, and now has a place here in Norfolk, Virginia, where I am. The model of, when we talk about supporting all children, ensuring that they all have access to the physical, mental, and relational health, medical homes or primary care is a logical and such an important sector to think about. This is where children's healthcare happens. The model already focuses on both prevention and intervention and requires actually screening over the first couple of years of life. Probably most importantly, as with childcare, as with home visiting, families already trust their medical home. And so we partner with these tremendous professionals in a place where families come to seek guidance about their children. We also choose the medical home because our pediatric partners are tremendously skilled, but have no required clinical rotations in child mental health or child psychiatry. Our model of consultation is consultee driven, meaning that they can choose what they want to use from our program, starting from the least interactive, using point of care guidance and handouts from our websites, participating in service training, which we've done so much more of in the last 2 years. Even pre-COVID, we were doing telehealth consults by Zoom, as well as indirect consults, which is what we call talking about a child's mental health with the provider, but not directly with the child and family. Direct consults is with the family. And in 2018, we added an additional referral support piece, recognizing that link to specialty care was really a challenge for our partners. On the next slide, in thinking about how do we promote early identification and support that first line management, we want our partners to be familiar with a discrete set of tools, just slightly bigger than what you can see right now. Starting in the left-hand corner, we want to make sure they're all comfortable with screening for social emotional health, which the AAP, American Academy of Pediatrics, does not require, but recommends in the preschool age group. And we use the early childhood screening assessment to respond to one of the pieces in the chat. There are other measures. The baby and preschool pediatric symptom checklist is also useful for primary care settings. And in other settings, the ages and stages questionnaire social emotional can also be used. We want to make sure that they have a familiarity with talking about selective attention. So we have a handout, that pyramid on the top, focusing on positive attention for positive behaviors, not giving attention to the unwanted behaviors, and making sure that they have a plan for talking about safe, consistent consequences for unacceptable behaviors. We support them in developing more effective communication skills using a tool developed by promoted by the American Academy of Pediatrics, and that's intentional. We want to use their professional organization to provide the tools to support the relationship we're building and their trust in what we have to offer. On the left, you can see we support we teach our partners ways of helping children and families self-regulate and using relaxation skills and mindfulness skills. On the bottom, for some reason, you can't see, oh, there we go. We want them to be familiar enough to talk with early childhood caregiver-child relationships that they can use something like the Circle of Security handout to talk through what a child's emotional needs might be. And we want to make sure parents are at the center. So Vroom is one program to support parents in positive interactions with their child. And we always, as Allison mentioned, we always make sure that we're helping them think about the well-being of the caregivers as well. On the next slide, you can see we have the two-lane model in the last 2 years has dramatically expanded in terms of the geography and the number of providers involved. The consult model includes on-site and off-site consultation. And you'll see in this slide and the next one, on average, pediatricians ask for help around kids who are 51, 52 months old. In Louisiana, the children that we have data about race suggests that we're able to provide consultation proportionately to the children in our state, although we probably need to continue to improve our process of collecting that data. I do want to highlight that these are children who have significant needs, and almost half of them have already been exposed to adversity before the consult. And you can see in our problem domains that trauma is one of the major areas of focus in the consultation, and Faye will talk to you about autism spectrum disorder, which is also quite prominent. On the next slide, our expansion into our expansion to Virginia started in 2020. We have a much smaller program right now, about 0.15 FTEs of consultation in 2 practices predominantly. We are able to address some of the disparities that exist in infant and early childhood mental health: age, race compared to the city where we're providing care, ensuring that children who are eligible for Medicaid by income are able to access our services. And we have not really nudged the disparity of access of girls being less identified than boys, despite equal rates of illness. The next slide, in terms of outcomes, and I know I'm running over, so I'm going to go quickly, but our outcome, we do have in both sites similar outcomes. Our partners are doing what we're teaching them, using screening, using relaxation, positive reinforcement, that pyramid, and they know more about ADHD. And also here in Norfolk, they know more about they say they know more about healthy caregiver-child relationships. So what do we want to do? We're expanding our educational approaches. We're developing a peer navigation approach here in Norfolk, partnering with a program providing mental health education in the community through predominantly Black churches, and want to look at the impacts of consultation on the community. We're integrating this work into pediatric training programs as well, and we're grateful to be part of some educational, larger educational venues, including here. And lastly, we want to be sustainable, so we'll work on our value-based care. Faye is going to tell you about the children with autism spectrum disorder.
Thank you, Dr. Gleason. So I'll expand a little more on how we addressed that third of referrals we got in that 21 year related to autism and developmental delay. There, an increasing need arose when COVID further limited our already short supply of physicians and psychologists who provide these diagnoses that were required by insurance for the children to access ADA services. And many clinics were reassessing their evaluation process as the ADOS required close contact and was rendered invalid with any facial protective device, since it wasn't standardized. We also have, families and PCP hesitancy, kind of given the years plus long wait lists for diagnosis, discomfort with discussing the diagnosis, as well as management of these concerns. Next slide, please. So as a result, we expanded our model to include virtual autism consultation. The goal of these brief evaluations was to gather enough clinical information to make a diagnosis and channel these children who presented with clear signs and symptoms into early intervention. Next slide, thank you. So we consulted with our colleagues at the Autism Center to kind of explore what a consultation might look like, how we can best still gather that information and data to make the diagnosis, how to kind of bridge the gaps in our current system that was rapidly kind of evolving due to changes in rules and with COVID. So next slide. Our consultation ultimately involved a Zoom session with a family member and the child, where we gathered comprehensive developmental history as we made observations of the cameras on the child. We also gave the caregiver specific tasks to engage with the child as we're kind of, again, looking for these signs and that were concerning for autism. We then did a second session where we provided feedback to the family and kind of discussed, these things that were included in our report, the preliminary diagnoses, referrals, recommendations for resources. And we also then got back with the referring provider who got a copy of the report, as well as a phone call to kind of address any concerns they may have with navigating, coordinating care for these young kids we were making diagnoses for. So in addition to each specific, I'll mention case that we were working with them on, we also tried to provide didactics for primary care providers to inform them about autism detection, diagnoses, and care management. Our team also formulated these information guides targeting families and providers that are now available in clinics, which shows on the next slide here. Sorry, back one, please. There we go. So the one on top is our guide that explains a little bit of the autism evaluation process, which starts with positive screen at your primary care follow-up. A positive screen would then trigger a referral to comprehensive autism evaluation at one of the autism centers, as well as suggested kind of referrals for intervention for them to kind of start ASAP. And we kind of plugged ourselves in as, if necessary, if the need arose in acute cases, wait list was too long, if they wanted our involvement, we were happy to provide a consultation kind of in addition to the other supports at that time. The bottom shows our parent guide that goes into a little more detail explaining what autism is in layman's terms, examples of signs and symptoms to look for, as well as why these things may be concerns and why it is we want to diagnose early and refer early if that were the case. We also introduced kind of the various interventions available, including breaking down, what is ABA, speech, occupational therapy, and medications all being ways in which we manage autism at this time. And in addition to that, some resources for families to gather more information, both online as well as locally in the community. So next slide, please. And to kind of wrap up, moving forward, we definitely want to aim to continue providing support for our primary care providers through education and feedback, really addressing their questions and empowering them to be able to refer at the earliest concern and sign for a comprehensive assessment and intervention, so that we also to kind of help facilitate that. Very exciting news is that we have been able to collaborate with the Autism Center at Tulane to help provide these children who are coming in under 30 months of age with next available assessments to kind of help bridge that really long wait list and concerns from families and primary care providers. So next, I believe, is going to Juliana.
Thanks so much, Faye. So I'm going to be talking a little bit about a perinatal mental health program, perinatal mental health consultation program that we have here in Louisiana called LAMP, or Louisiana Mental Health Perinatal Partnership. I'll talk a little bit about our funding and a little bit about where we are. And then we will have some time for questions. I know there have been some great questions in the chat, so I'll make sure to save time. So LAMP is Louisiana is one of the 7 states who received this initial HRSA funding to provide a perinatal psychiatry access program for our state. So we're a 5-year program. We're currently in our 4th year of funding, and we're administered through the Louisiana Department of Health's Office of Public Health's Bureau of Family Health. And what we provide is statewide perinatal psychiatry consultation to frontline healthcare clinicians. And so when that comes to when we're talking about perinatal psychiatric consultation, we're including OBGYNs, of course, family physicians, but also pediatricians who are screening for maternal depression, mental health clinicians as well, non-prescribing mental health clinicians, but also psychiatrists, and I'll talk a little bit more about that, nurses, advanced practice RNs, and nurse midwives. And so those really are target in terms of our perinatal consultation. I apologize, I'm having a little bit of trouble with our slide progression here. So the goals of our program, as we've talked about with some of these other programs, is firstly to increase universal screening for depression, anxiety, and substance use disorders in the perinatal period. So that's through pregnancy and then that first year postpartum. But also we've added screening for intimate partner violence and providing first-line intervention as well, because that's such a huge problem in our state as well as nationally, and is one of the causes of pregnancy-associated death a leading cause, actually. We also then want to increase early detection and evidence-informed first-line interventions. And that includes interventions that an OBGYN or a family physician can do, and that may include medications as well in pregnancy and postpartum. We support also referral to specialty mental health services when needed, but also access to basic needs resources and other community-based resources across our state. And as you can imagine, the availability of those resources varies depending on the region. And one of our targets, of course, with our HRSA funding is rural and underserved areas. And then finally, we're always looking towards developing a plan for sustainability beyond our grant funding. So a little bit about the components of our program. So as I mentioned, we provide statewide consultation. So primarily what we're providing is phone consultation to clinicians. We have full-time resource and referral support, and then we have about 30 hours a week of real-time psychiatry support. So ideally, within kind of real time, a psychiatrist can get on the phone and guide a prescribing clinician with questions about medications, discuss next steps, safety, etc. We also do, as Mary Margaret mentioned too, and everyone's been talking about, we've really leaned heavily on our training support, especially during COVID. It's been wonderful to be able to expand kind of the reach of our training through webinars, record both live webinars, and also we record all of our webinars and put them up on our website. So any clinician can access them at their own pace. I mentioned our website, so we have, as with the other program websites, clinical tools, handouts. We have a resource database I'll touch on a little bit that is, again, public facing, where providers can search by region, by payment method, and by what resources they're looking for. We do provide, when there isn't a pandemic, we provide on-site mental health consultation in 3 regions of our state. So here where I'm located in New Orleans, and then also in a region that's sort of a mix of urban and rural communities, and then a region in the northern part of our state, which is struggles more with access to resources. And finally, we do offer telehealth consultation directly with patients in select cases. So because we're statewide, we do rely heavily on that indirect consultation with providers, but when needed, we can also do face-to-face with patients. A little bit about our training. So again, this has been a big focus and a big pivot with COVID, is to really focus on our trainings. And so since our program started in 2019, we've provided about 55 trainings at this point. So again, with the pivot to COVID, most of those trainings have been offered virtually. And then on a whole, about 327 unique clinicians have participated in our training. So we have a nice group of clinicians who participate on a regular and ongoing basis. And so we've developed a community around that. 209 unique providers have sought consultation, whether that's patient specific or just general consultation about considerations in the perinatal period, and really a range of questions. So I put some samples on here. Pediatricians calling, looking for parenting resources. But there we get to squeeze in some information about screening and the importance of universal screening. Family physicians saying, I have a patient who stopped all of her medications. What do I do? I'm not trained in this. And so there we can discuss, for example, the importance of sleep hygiene and the importance of parenting supports and mobilizing other supports for that individual. OBGYNs might call with thinking it's a simple, straightforward question, which SSRI do I start? And maybe we're having a discussion about the difference between grief, typical grief versus major depressive disorder, and about peer supports and therapy. And then finally, we do have a fair number of consults from non-prescribing mental health clinicians whose prescribing clinicians stop their medication and the patient's doing worse. And so there really our role is to help that non-prescribing mental health clinician help their patient advocate for herself with her prescribing physician. A little bit about, just to touch on advocacy efforts. So some legislation passed in our state last year established a perinatal mental health task force, and we've contributed some subject matter expertise and support with drafting a policy brief. Our Governor appointed perinatal commission has finally this past year developed a mental health work group, which is wonderful that there's some increased focus and we participate in that. Substance use disorders in the perinatal period, we have a work group again through Louisiana Perinatal Quality Commission. We participated in the network called Lifeline for Moms, which is the network of perinatal psychiatry access programs. And And finally, just last week, we participated in some federal advocacy efforts. So speaking with our senators here in our state, advocating for the importance of funding for addressing perinatal mental health concerns. Future directions, we are working as a program to incorporate more inclusive language into our website, our clinical materials, our trainings. We're really trying to collect better data regarding demographic data so we can assess whether our consultation program is addressing inequities in mental health care. Really importantly, we want to increase the diversity of our workforce, and that includes the visibility of and access to culturally responsive clinicians. And then finally, increasing our linkages with community-based sources of knowledge and strength, including doulas. We'd like to engage more with doulas in our community. So I'll pass it over to Dr. Gleason, I think.
Actually, that's me, but that works. I'm just going to do a real quick wrap up so we can get to some of your questions. Really, when we're looking at all of these goals, I think all of us across programs realize that sometimes the work that we're doing in supporting that healthy development of young children and identifying and linking children and families to services, that it can become quite consuming. And so we've, I think, all found that it's important that we take that step back to focus on system change, to focus on advocacy and on mitigating inequities, and realizing that while all of the work is important and the first several goals do start moving in that direction, that across sectors we need to consistently think about refocusing our efforts and engage with our communities so that we can support this longer term system-wide change. And that a key component in reaching that change is to have collaboration between partners and across sectors. While there are differences across all of the sectors that we're talking about today, there are so many similarities across them. And the more often that we can reach out and find our partners who are all focused and believe in the importance of raising happy, healthy young children wherever they are and wherever they come from, helps us to improve long-term sustainability of programs and to make sure that we're consistently meeting the needs of the young children and families in our communities. So I'm just going to hop in and answer a couple of questions that came in during my talk that were related to childcare. The first was around social emotional screening tools, and Sarah put a link for their website that has several of those tools. The primary ones that TIECHS uses is the EXA, which Dr. Gleason developed, as well as the ASQ and the ASQSE. Those are our primary universal screening tools. And then when we're using more focused screening tools, we'll use the CBCL and the DECA. And then another question was about how long we stay on site. When we're in childcare centers, we aim for around 5 hours. If it's a smaller center, a little bit less. And if we're working with a family childcare provider, it's usually about 1 to 2 hours because it's just us and the provider in the home. Thank you.
And I'll jump in real fast on the Medicaid eligible question. Are we billing Medicaid? Currently, no, but we have been working on this issue for years. Mary Margaret is smiling because she and I have been in the thick of this for a while. There are a lot of efforts around what that would look like. In some states, there are some codes available that may be able to be used, but at this point, we have been dependent on grant funding. But working more towards sustainability and seeing how Medicaid can be used. So we have a whole work group around that. And also 0 to 3 has a funding policy work group that is 20 states are involved with that and talking a lot about those issues there.
And I'll just say on the primary care side, a tweak that we've done here in Virginia is that for the face-to-face consults that are in the practice where we provide consultation, we are billing for those and still use external funding for everything that goes around that, the in-betweens. So it's a step in one direction, and I think it's a really important question.
There's a question about regions too. So the primary care started in the New Orleans region and has expanded to the Baton Rouge. So the two major metropolitan areas. And then home visiting is statewide, TIECHS is statewide, perinatal is statewide. What else are we missing on that question? Anyone?
Did you mention Region 4?
I did not.
Yeah.
You want to?
So there is primary care consultation through that through the left that has carried over from the launch, the federally funded project, as well as someone asked about early intervention. We didn't have time to talk about consultation to early intervention today, but has been a really important part of the work that we've done. And our early intervention partners are among the most enthusiastic consultees. So just want to acknowledge that.
I see one last question in there that I'll try. Oh, I think Allison just answered. We do use licensed mental health clinicians as our consultants, I think, in all programs. Yeah, and I think we're at time.
I was just going to say perinatal and primary care also have physicians on the team. So that's that multi-level consultation as well. And here we also have psychologists on the primary care team.
Just to touch on that last question about early intervention services, anywhere in the country, kiddos 3 and under would qualify for an early steps assessment and evaluation, as well as treatment provided for free, and that includes speech, occupational, physical therapy, sometimes behavioral interventionists, depending on the team available locally to you. I think maybe that's what, I'm not sure if that answers your question, but I want to throw that out there.
Just, I'm not sure if this is what the question was touching on, but we do recognize sometimes there's those delays in getting a comprehensive diagnostic eval for autism. So the idea is really to provide a diagnosis when we can, to prevent delays in getting that child really on the wait list for autism specific services. So that's really part of the goal that Dr. Chen was discussing.
So I think we're at time, but thank you everybody for attending.